Morning and greetings from Sheffield. Over the next 5 minutes, I'm going to take you through our experience of surgically managing complex pressure ulcers at the Princess Royal Spine Injury Center in Sheffield, which is a tertiary spinal injury center which covers most of the north and east of England. The work that I'm going to present has largely been done by Lisa Grandidge, who's my specialist registrar and who's coming to the end of her training. And this really takes us through our experience of the last few years in managing complex pressure ulcers. Lisa would very much like to have been here and had been awarded the Rising Star Award, as I understand, when the original abstract was submitted in 2020. The aim of this presentation is to look at the outcomes following surgical management and to review the frequency with which we identified deep osteomyelitis and the organisms that we found in our cohort of patients. To set the context for this, it is useful to look at the type of patients that we are treating. I mean, these are patients with complex grade 3 and 4 ulcers who have failed conservative management in the community. And these ulcers will usually have been present for many months or sometimes years before they are actually referred into what is a tertiary center. We tend to take a staged approach, which is a debridement of the wound, followed by a period of intensive dressing, which is then followed by surgical wound closure. Bone samples are usually taken at the point of debridement, which will then guide further management. Appropriate imaging is also acquired at various points along the patient journey. So this is a case example of what happens. So somebody presents with a very nasty pressure ulcer which developed during a cruise, and sort of the wound was debrided, and after a period of dressing went on to clean up nicely and was then surgically closed and went on to heal satisfactorily. So we looked at all those patients who underwent pressure ulcer surgery between January 2016 and September 2019. The details of the patients were obtained through hospital data systems. There were 306 pressure ulcer procedures that were carried out in 140 patients. And as I indicated, most patients will have had a debridement followed by a closure, and some will have had more than one debridement, which explains the difference between the number of patients and the pressure ulcers. And obviously, some will have also had multiple ulcers. So 2 patients required 3 separate admissions. The median age was 56 years with a range of 13. And the mean length of stay was 68.9 days. The patients on average had about 2 procedures. Now, the patients we treat are those with underlying spinal cord injury or severe neurological problems. Usually, the majority are spinal cord injury with a few spina bifida and multiple sclerosis thrown in. Now, amongst the spinal cord injured patients and amongst our cohort, there were 10 patients who came to us with pressure ulcers during the initial, immediately following the initial injury, and they required surgical management of it. So there were 171 procedures that we carried out. And in 40 of those, we did not have to do a separate debridement. The wound was clean enough for us to close it directly. The commonest site was the ischium, followed by the sacrum, and then the trochanter. There were a few foot and combined ulcers thrown into the mix. Heel ulcers were not included in this study because they were not managed surgically. So the vast majority of patients were treated with direct closure. So when we came to closing it, we did an end-to-end primary closure. And it is only in a minority that we had to use flaps. There were 9 patients who had hip infection and required a girdle stents excision. And there were 7 others who had fairly flat wounds that was treated with skin grafting. The other possibility is that they were unwell to undergo major procedures, and the skin grafting was used as a temporizing measure. And in 3 patients, after debridement, we used wax straight away, and in many others, we used wax systems as a measure to help reduce the size of the wound and to help with the cleaning up of the wound. 79, that is around 50% of patients had bone samples sent for microbiology, and of that, 89.9%, so around 90% were positive. So this is something that has been shown in other analysis as well, that there is a high incidence of bone infection in those who have persistent chronic ulcers. And interestingly, we found that the commonest organisms were Enterococcus and Corynebacterium. Now, this is not in keeping with what has been reported previously, and I suspect it reflects the fact that many of these patients will have had multiple courses of antibiotics in the community before they came into hospital, or sometimes at other hospitals before they came for specialist treatment. In the spinal cord injury group, the mean period between the spinal cord injury diagnosis and surgery was around 22 years with a range of 15 years. And in 15%, the pressure ulcer developed within the first 5 years of the injury, which suggests that in the majority, the longer they live with the spinal cord injury, the greater the likelihood of developing pressure ulcers, which is a well-recognized issue. And in our analysis, and the follow-up is not consistent because some people had been followed up for 3 years and others only 1 year at the time of the analysis. We found that 19 deaths that occurred, 9 of those were in those with spinal cord injury, in 2 with multiple sclerosis and 1 with Parkinson's disease. We have not been able to do a detailed analysis of why people died, whether it was in some way related to the pressure ulcers or whether it was completely unrelated. The median age at death was 70 years. So we also decided to take a look at the costs involved. And we found that if people just came in for a debridement, it incurred the lowest cost, as one would expect, at about £3,000. And for some of our very long stay patients where people had hip involvement and multiple pressure ulcers, the cost could go well above £100,000 to sort of the person with the longest stay having incurred almost £150,000 in cost. So our heal rates. So we decided to look at the 1-year heal rate because I think that is more reflective of true outcomes. And we found that the majority of wounds were well healed at 1 year. And there were 21 failures in the direct closures and 1 in the flaps, but there is a big difference between the number of direct closures and flaps that we used. So overall, the percentages broadly remained similar. So in conclusion, what we found was that the pressure ulcers tended to be more of a problem in those with complete injuries and in those with long-term spinal cord injury. The majority of patients we treated had direct closures, and our outcomes were comparable to flaps. The major advantage of direct closures is that the procedure is of a lesser magnitude, and often patients tolerate it better. Most required a 2-stage procedure, and we found that there was a 12 to 13% mortality rate, at the point at which we followed them up. And it is not entirely clear what the cause of that was, whether it was the pressure ulcer, or whether it was an unrelated cause. And there was predominance of Enterococci and Corynebacterium, reflecting prior antibiotic use. So we generally recommend that good monitoring is important in terms of preventing pressure ulcers. And if surgery is undertaken, close monitoring following surgery and the follow-up period is required, given that there is a significant rate of recurrence. And many of these patients will require multiple operations, and it makes sense to plan for that eventuality when we are deciding on what particular surgical approach to adopt. Thank you very much.